Welcome to the LACNETS podcast. I'm your host, Lisa Yen. I'm the LACNETS Director of Programs and Outreach, as well as a caregiver and advocate for my husband who is living with NET. In each podcast episode, we talk to a NET expert who answers your top 10 questions. This podcast is for educational purposes only and does not constitute medical advice. Please discuss your questions and concerns with your physician. Welcome to the LACNETS podcast. I'm really excited to introduce our guest for today, Dr. Osman Ahmed. Dr. Ahmed is a vascular and interventional radiologist from the University of Chicago. He has a special interest in cancer care, including neuroendocrine cancer, and he's able to treat cancers like neuroendocrine cancers that spread to the liver with different procedures that we will talk about today. One of these techniques is histotripsy, something that we at LACNETS first learned about from Dr. Ahmed back in 2022 when he spoke at our LACNETS Patient Educational Conference, and this is now a hot topic and something of interest to the NET patient community. Dr. Ahmed was one of the investigators that was involved in the trial that led to its approval in the fall of 2023. Dr. Ahmed has been a frequent speaker and a friend to the LACNETS community. We appreciate his innovative and multidisciplinary approach, and we also appreciate how he explains things in an easy-to-understand way. A fun fact about Dr. Ahmed is that he's a father of 4 kids, 3 girls and a boy, and they control his life quite literally because his 2 little daughters, their favorite hobby is to pick his clothes for today. So he has his own 2 stylists for his clothes and his hair, and in fact, he just got his hair cut, and the person cutting his hair noticed glitter in his hair. So what a fun fact. We love that. So Dr. Ahmed, welcome to our program today. And I'd love for you to introduce yourself and share a little bit more about how you got involved in the NET patient community or in the NET community at large.
Yeah, for sure. Thank you so much, Lisa, for having me on and the wonderful introduction and the embarrassing facts about my personal life. Well, as you mentioned, aside from my beautiful kids, I'm privileged to be an interventional radiologist. I work at the University of Chicago, where I did some of my training and now have been here for about 7 years, and pretty crazy how time flies. But as you mentioned, I have a strong interest with what's known as interventional oncology, which is sort of a niche of interventional radiology, which is treating patients with cancer, primarily involving the liver, but also other organs as well. And a natural extension of that, because of how involved we are with the liver, is treating patients with neuroendocrine cancer because, for better or worse, the tumor does tend to spread to the liver very often. And so for that reason, I've always been interested by neuroendocrine cancer. But then I've also been blessed by working at an institution that also has other specialists who are very passionate and involved with neuroendocrine cancer. So as I'm sure we've talked about multiple times, it's very important to work in a group that is very multidisciplinary, very collaborative, and both from the patient side as well as the physician side, this is very important to get really optimal care with neuroendocrine cancer because of how, nuanced and unique this cancer is.
Yeah. So we really appreciate your part in helping patients get that optimal care. So we invited you to this program, and we really appreciate you being on because we've been doing a series where we focus on various treatments. And as you mentioned, a lot of patients, their cancer tends to spread, particularly to the liver. So we've covered various topics that address when those cancers spread. So somatostatin analogs, targeted therapy like everolimus, PRRT, chemotherapy, immunotherapy, and of course, we wanted to talk about liver-directed therapy because that is of interest. There's a lot of buzz, as you know, about histotripsy, so we'll certainly talk about that. And as we delve into this, I think even before talking about histotripsy, one of the foundational things we should talk about is what is liver-directed therapy and how does it work? Let's start there.
Definitely. So liver-directed therapy is almost what exactly it sounds like. It's delivering therapies that go directly to the liver or target the liver specifically. And as you've mentioned, Lisa, neuroendocrine cancer tends to spread to the liver very commonly. And that often is a sort of battleground for us to try to treat because the liver is a very important organ for daily functions of our life. And so we want to really try to kill or shrink as much tumor in the liver as possible to preserve that normal liver. And so the benefit of some of the therapies that we're able to offer is that we are able to get really close to those tumors in the liver and deliver our therapies to those tumors. The benefit of that is you can give very high concentrations or give very focal treatments without some of the potentially negative side effects of what are known as systemic therapies that go throughout your whole body. So that ratio of tumor kill to damage of normal tissue is optimized with liver-directed therapies because we're able to really focus and concentrate the therapy to the tumor in the liver and really minimize the collateral damage to the normal liver or rest of the body.
Thanks for explaining that. So it also kind of helps explain how to understand it in the context of other treatments. So this is another basic question, but is this considered surgery? And if it is or isn't, how's it different or similar to surgery?
By definition, it's not surgery. You may find some interventionalists who may refer to it as surgery, or even patients may refer to it as surgery. In a way, it is kind of like surgery, but I like to call these procedures. And it's mainly just framed that this is minimally invasive. And while there is an incision, it's usually a puncture, meaning less than an inch puncture or incision. So while these seem surgical, we do them in a sterile fashion. Sometimes these procedures involve the use of anesthesia. These are essentially procedures for that reason. Now, interventional radiology is kind of a unique specialty in that it is kind of like a hybrid of radiology and surgery. Historical fun fact, I think when they were trying to pick the name for the specialty, because it's not that old, it was invented in the late 1960s. I think radiologic surgery was one of the names that they actually had tossed around. But ultimately, I think our forefathers decided that interventional radiology is a more apt term for what we're doing because it's not like a full surgery the way we conventionally think.
Yeah, thanks for distinguishing that procedure versus surgery. That really helps us understand the context. So let's talk a little bit more. What are the different types of liver-directed therapy used for neuroendocrine cancer?
Yeah, for sure. When I try to explain to patients what we can offer for cancers and specifically cancers of the liver, I like to broadly categorize it into two buckets. The first bucket is probably pretty easy to understand. It's what's known as percutaneous ablation or ablation modalities. What ablation is, conceptually, it's taking a needle and directly putting it through the skin into the tumor. Once that needle is in that tumor, you can basically blast that tumor away with what's usually known as thermal energy. So you can either burn it or freeze it. And then there's other types of ablative modalities that are non-thermal. And histotripsy is one of those things. We'll talk about that later, I know. And then the other big bucket is what are known as intra-arterial therapies, where you can actually take a very small tube or catheter and guide that through the artery, either in your groin, which is known as the femoral artery, or in your wrist, which is known as the radial artery. And you can guide that catheter through the arteries using X-ray to guide you all the way into the arteries that feed the liver, and specifically to the arteries that feed the tumor. And then you can deliver some therapy, whether that's chemotherapy, whether that's radiation therapy, or what's known as bland embolization, where you just put bland beads, like grains of sand, to plug up the arteries. And so that's what are known as intra-arterial therapies. And again, in that bucket are therapies known as chemoembolization, radioembolization, bland embolization, and the concept is the same. It's just what you're delivering is different.
Wow, thanks for clarifying those two buckets. So the ablations being the ones that we directly target the tumor, and the interarterial that are feeding or cutting off or doing something directed towards the tumor.
Correct. And both of these procedures are essentially equally as minimally invasive in terms of when we talked about the puncture or incision site. It's going to be like half an inch incision. And the vast majority of the time, we're basically placing a Band-Aid and the patient is either going home that day or early the next morning.
That's reassuring that it's less invasive. So how do you decide who's a good candidate and if it'll be effective for various patients?
You know, I think determining who is an ideal candidate, just like I think all things in neuroendocrine cancer, we talked about this, I think everything should be done in a multidisciplinary fashion. So together with our medical oncologists, our surgical oncologists, as well as even our diagnostic radiologists, we want to do this not in a silo, but as a collaborative group to figure out who would be an ideal candidate for these therapies. Now, in general, the most ideal candidates are what sound to be pretty obvious, which is people who have cancer or tumors that are primarily localized to the liver. Because if you have cancer throughout the whole body, then it may not make that much sense to just target one organ. However, conversely, if you do have only one or two tumors and they're only in the liver, then that's my wheelhouse. That's where I can really hopefully offer something very targeted for you. And then there are some other indications where we will do liver-directed therapies. One of the other more common one is you may have tumors throughout the body, but some of these cancers can be hormonally active. And so if you have a lot of symptoms from them or side effects from them, the liver is oftentimes one of the most bang for your buck type of areas that if you can kill a lot of tumor in the liver, then you may get some symptomatic relief from those side effects. So that is another common area that we will offer these liver-directed therapies for.
Okay, that's helpful. And when are liver-directed therapies not used? I've heard maybe someone with a Whipple may have certain limitations, for example.
So I would say the people that are not going to be eligible for liver-directed therapies, this is some of the common sense stuff, but it's good to just reiterate, but it's people who are not healthy enough for them. We'll often include in that category the people that similarly not be healthy enough for chemotherapy, meaning their liver function has deteriorated too much to the point where if you do one of these therapies, you actually may hurt somebody as opposed to help them. You may actually damage too much of the normal liver, even with the minimal collateral damage that we have with our therapies. It may actually push you over. So if your liver function is not good, then we would pause and probably not offer therapy. Similarly, if you're what's known as your performance status, so if you are healthy, active, then you're more likely to tolerate the hit that we're going to give you with this therapy versus if you are very sick, meaning you're bedbound, having difficulty getting up, having a lot of fatigue, things like that. Similarly, with the concept that we don't want to hurt you, we obviously want to offer a therapy that will help. So those are sort of what I would say are the main contraindications to having our procedures. And like I just mentioned earlier, it has to make sense. We have to be doing something that will hopefully add value. So if you have cancer throughout the whole body, then doing something very targeted may not make sense. And it may make sense to do something else like a systemic therapy.
Yeah, thanks for explaining that. So if we could maybe hone in a little bit on ablation, and if you would explain the different kind of ablations that are out there, because we hear different terms like microwave and radiofrequency, and what are these different ablative techniques?
Yeah, totally. So ablation is that first bucket that I referred to, which is taking a needle, putting it into the tumor, and then connecting it to a machine. And then that machine will decide what you're going to do. So obviously, it's a lot more complex than what I just said, but that's really, when you boil it down, that's what's happening. Now, we're fortunate in our specialty that there's always innovation. There's always new technologies coming out. Ablation is no stranger to that. There's been a lot of innovations and improvements in terms of the things that we can offer our patients. And so with ablation, we have a lot of different technologies. And so under the thermal ablation category, which we said is a temperature-based ablation, we have heat-based, which is radiofrequency or RF, and then we have microwave. And really, microwave is kind of the new version of RF. So for the most part, we use microwave unless there's various nuances where we may use RF. In Asia, for example, they still use RF just because it's more commonly available. And then under the cold category or the freezing category, we have cryoablation. So we can also freeze tumors. We don't do a lot of cryoablation in the liver just because it tends to have a little bit more side effects, but you can do it. But we do cryoablation in other parts of the body more commonly, especially when a tumor is close to the skin because the ice is more forgiving to the skin as well as if it's close to nerves. These are just very general classifications. And then we can also do what's known as non-thermal ablation, which is basically killing tumors without using heat or cold energy. One of the more common ones is known as IRE or irreversible electroporation, where you can actually put needles around the tumor, bracket the tumor, and then basically electrocute it. So it's like trying to put like a electrical fence around it and then zap it. So IRE is getting pretty popular and more commonly used, but it has its own positives and negatives as well. So it's not like one size fits all. So there's multiple options. And I'd probably say the newest sort of kid on the block with respect to ablation is histotripsy. And it's very different because among many things, it's non-invasive as well as non-thermal. So it relies on the use of ultrasound energy to zap tumors. And so that doesn't use heat or cold energy.
And that's certainly very exciting for patients. So before we get into histotripsy, I've heard that there's an ablation zone or heat sink effect. Could you explain those concepts?
Yeah, so ablation zone is the area of dead tissue that you are going to create with your ablation. So if you have a 3-centimeter tumor, we don't want to just burn 3 centimeters. We want to burn a little bit more so we have a zone of normal tissue that we've killed around it. That concept probably makes sense to most people, but it's important to obviously get what's known as a margin. We want to make sure that we also get some healthy tissue around the tumor. So when we do ablations, we want an ablation zone to be ideally at least 5 millimeters beyond the tumor. And in some cases, or a lot of cases, we want it to be even up to 1 centimeter. And that ensures that we get good outcomes. And so that's your ablation zone. Now, heat sink is one of the limitations of heat-based thermal ablation, so RF and microwave. And heat sink is what happens when a tumor is very close to a big blood vessel. Blood vessels are, imagine it as if it's water kind of bathing the tumor. So if you start heating up a tumor, let's say you put the needle in the tumor, you start heating it up, but you have this water running alongside, like a river running alongside the tumor, it's picking up some of that heat energy and taking it away. So the rim of tissue that's very close to that vessel, especially with larger blood vessels, that heat is sinking or carrying away what you're trying to do, which is trying to kill that tumor. And so what usually happens when you treat a tumor with heat-based energy near a large blood vessel is you risk getting what's known as the heat sink effect, which is residual tumor along the margin of tumor adjacent to the blood vessel. And so that's one of the main reasons why RF, radiofrequency ablation, has been primarily replaced by microwave, because microwave can overcome this phenomenon better, but it is still subject to this potential side effect. So for this reason, if we do have tumors that are adjacent blood vessels, we may consider other ablation modalities, like an IRE, for example, because it's non-thermal, it's not subject to the heat sink effect.
Okay, thank you for explaining that. So perhaps this is the perfect time to also ask about histotripsy. What about histotripsy? And would it be subject to that? And just in general, when is it used?
So histotripsy is really exciting, as you mentioned, because it is another form of ablation. And with ablation, we typically require a needle going through the skin and into the tumor. And so what's unique about histotripsy is you can achieve the same effect as other types of ablation without actually putting anything through the skin. So it's completely non-invasive. So we've gone from minimally invasive to actually now non-invasive. And what it does is it relies on this phenomenon of cavitation. The type of energy that histotripsy utilizes is ultrasound. So just like the ultrasound that you use to look at a baby when a woman is pregnant, it's the same type of ultrasound we use to localize the tumor, but then it can actually emit a certain frequency that causes a phenomenon known as cavitation or bubbles. And if you can concentrate these beams on one focal area, you can create these bubbles that essentially cavitate the tumor away, or basically liquefy or melt the tumor down, again, without using thermal energy. And so it's really, really exciting because you can do this all without putting anything into a patient's body. And so that's what's really led the buzz, part of the pun there, for histotripsy. But what's also been noted, and I think what's really getting a lot of people's attention, is that when you do this, it also seems to really wake up the immune system and really activate a patient's internal immune system that we typically use to fight infections. But the immune system can also target tumors. And so what people have been noticing is that it seems to actually wake up the immune system, and it can actually potentially target other tumors and not completely kill them, but help shrink them. And so there's a lot of interest in potentially using histotripsy in combination with immunotherapies, for example, which work on the immune system to help get what are known as synergistic responses. The sum of these two therapies is actually better than both of them individually.
So that's really exciting. And of course, people are very excited because of the whole idea of it not being invasive. So when is it able to be used? Like, is there a certain tumor grade, type of tumor, and location?
Yeah, I'm glad you asked that, because I was going to go into that. I think what's important to know about histotripsy is it is another ablation modality. And so when we think of ablation, we typically think of treating patients who have just a few tumors. Because if you imagine taking a needle and putting it into tumors, if you had 100 of those, it's going to be very difficult and going to take forever to do, and it doesn't make sense. As you're probably causing more harm or risk than benefit. And that's why we have intra-arterial therapies. When you have multiple tumors, we actually opt for those intra-arterial therapies, because coming from the inside, from the arteries, you can treat all those tumors all at once. Now, histotripsy I look at as another form of ablation because of how it works. So typically for ablation, we are targeting patients who have 3 tumors or less, and the size has to be 3 centimeters or less. And the reason for that is because any type of ablation technology can only create an ablation zone that's about 3.5, 4 centimeters. Now, you can put multiple probes in and do larger ablations. You can do larger zones for histotripsy. It does take a lot more time. And the data suggests that when you start ablating things that are larger than 3 centimeters, the outcomes aren't as good, meaning there's probably other options that are better, like intra-arterial therapies, surgery, things like that. So for me, I typically will offer histotripsy for patients who fit into that category.
I'm glad you clarified that. I think it's hard to understand because it's a non-invasive technique. How come you can't do multiple tumors? I mean, can't I just come back and do it again? Especially if nothing else is an option, wouldn't a non-invasive procedure be right for me?
Yeah, it's a great question. And I think it's a question that I get asked often. And I think it's important to understand goals of therapy, like we talked about. We want to do something that can actually help and make sure that it provides a benefit. So while it may seem like there's little or no downside, there's no such thing in medicine, unfortunately, as only benefit and no risk. And that is the case with histotripsy as well, because ultimately this is a procedure that, even though it's not invasive, it does still require general anesthesia. So anesthesia always carries its own risks. And we've never really had any evidence or data to show doing multiple ablations for many, many tumors really adds any benefit for patients. And so while I think in general, proceduralists like myself and many patients would prefer to commit the error or sin of commission, which is do more rather than do less, we do have to pause and always make sure that we're doing the right thing and what's appropriate. And so it may be the case that ultimately one day we'll have studies that show, yes, doing multiple histotripsies or multiple ablations does make sense. But I think until we have actual studies that prove that, we shouldn't be doing medicine in a way that goes against what we know and what's established in therapies.
So what do the studies show so far? What's the rate of success of patients being treated? And I guess the big question on patients' mind is, can histotripsy cure neuroendocrine tumor?
So I think just like other ablation modalities, the early data on histotripsy has been excellent in terms of showing that when you can successfully target a tumor, the success rates of killing or blasting that tumor away are very high. So for that reason, I think anybody can get histotripsy. I will typically screen them and offer histotripsy as the first line therapy because it is not invasive, and I think that there's added benefit from that. Now, as far as it being a cure for neuroendocrine cancer, it's primarily only used in the liver, meaning if we are treating the liver, that means by definition the neuroendocrine cancer has spread to the liver and you're at a stage 4 or metastatic disease standpoint. So can it cure that tumor that we're treating? Yes. But can it cure the whole tumor? No, because it can't treat what the primary site of disease is. And so it can work as effectively as ablation does, meaning it can kill tumors that we're specifically targeting.
And thank you also for clarifying where it's used really only in the liver, because we get these questions. Can it be used in the pancreas? Can it be used in the lung? Can it be used in other areas of the body? So right now it's limited to the liver.
Yes, definitely.
So what are the other limitations I've heard, like if the tumor's in the liver, but under the ribs, you can't get to it? I don't know if there's any other specific limitations that you know of.
I think that's one of the other important things to talk about histotripsy is that it's a wonderful technology. And if I think a patient is eligible, I definitely offer it. Now, with that said, the technology is somewhat limited currently because it is an ultrasound-based technology. And ultrasound, for better or worse, gets blocked by bone and air. So unfortunately, the liver sort of lives under the ribs, which is bone, and right under the lungs, which is air. The lung kind of drapes over the top of the liver. So functionally, that leaves the bottom of the liver as the ideal targets. So in addition to those 3 tumors less than 3 centimeters, we typically are looking for tumors that are sort of more along the bottom edge of the liver. Now, with that said, I do know the company is working on improving the ability to treat tumors that are throughout the liver. But for now, we will screen or scan every patient in our clinic to see if they are eligible. And if they are, then we can offer the treatment. But I also know by looking at scans that if the patient's tumor is, near the dome or the top of the liver, it's less likely that we can offer that therapy.
Thanks for explaining that. Are there any other patient characteristics that you take into consideration for eligibility for histotripsy?
I think those are the primary characteristics, not to beat it over the head, but very similar to the way that I look at patients who are eligible for ablation. This is ultrasound, and I'm not sure how much people know about ultrasound, but the strength of the ultrasound gets diminished with the larger a patient may be. So the more tissue that you have to go through. So obese patients, for example, will likely be less eligible than patients who are much skinnier because the ultrasound beam doesn't have to travel through as much tissue. One of the benefits of neuroendocrine cancer, I don't know if benefits is the right word, but basically one of the things that happens with neuroendocrine cancer is the liver actually tends to enlarge with these tumors, which is actually a good thing for histotripsy because that means the liver grows and goes down more into the belly. So it is actually potentially more advantageous for histotripsy because it's away from those ribs. So again, if those tumors are lower and the liver is enlarged, there's a good chance that you can be eligible for the therapy.
And what happens to the liver tissue after ablation or histotripsy? Like what's actually happening to those cells, and is there damage to healthy tissue?
Yeah, there's damage to healthy tissue just in the way that a typical ablation is, meaning with histotripsy, we'll draw a zone of ablation around the tumor. So we will have a little bit of a healthy, normal tissue. And what happens is, I've seen this on animal models where we've had the chance, especially early on when we were learning the device, we would do histotripsy on an animal and then look at it on pathology. And basically it looks like the way that an asteroid hits the Earth, or not Earth, hopefully a different planet, but it just forms like this giant crater because it can essentially blast away that tissue. And what it does is it essentially liquefies that tumor down. And it obviously kills the tumor. And this is leading into why we think it may actually be beneficial for being synergistic with other therapies, is because it keeps some of the what are known as the antigens, the cell markers of the tumor, intact. And those are very important for the immune system to recognize and generate a response. And so it seems to do a better job of that than other therapies, which can also promote tumor immunogenicity. So the tumor is dead basically at the end of the histotripsy, but it does preserve some of those key antigens that can potentially be synergistic with other therapies.
And then what happens to the dead tissue? Does the body reabsorb it?
Yeah, great question. So it does over time just form a scar of that area. We've now done enough histotripsy where we've seen on our follow-up scans that that tissue or area just ends up resorbing away, becoming just like a scar on the scan.
Yeah, so there's a lot of wonder, like what's the recovery like for patients? I've heard patients report they're fine the next day, and others say it takes weeks and weeks for them to recover. Why is there a difference?
Good question. I would say our experience so far to date has been more that former, meaning patients typically go home the same day and then report doing well. Now, I think patients may feel lingering pain depending on where you treat the tumor. So if you have a tumor that's very close to the surface of the liver, for example, what's known as the capsule of the liver, that tends to be more painful. So if you're treating a tumor maybe along the capsule of the liver, you may have some lingering pain or things like that. That would be my guess for why patients may have some additional pain.
And does it matter in terms of the size if you would have lingering symptoms or side effects?
Yeah, I mean, I think in general, bigger tumors probably may create more inflammation and may have a little bit more pain, but I wouldn't expect it to be maybe more than a day or two difference.
So a practical question is, of course, curious minds want to know, where can I find this? How much does it cost? And what do I do if there's denials from the insurance company?
Great question. So I believe the Histosonics website is a good resource because it does have a physician finder or histotripsy finder application. So I would encourage you to maybe check the website out to see who's currently offering the therapy. And then obviously they make the machine. So every time they sell one, I'm sure they're updating the website with who else is asking. And so I think that would be a great way to find who's offering it and scheduling an appointment that's most convenient to patients. And then as far as insurance, we've been fortunate that we haven't had any issues just yet. But just like any new technology, there's always kind of a back and forth, meaning there's like a honeymoon period where it seems like it usually gets approved. And then there's this period where denials may start coming because insurance companies say, hey, what's going on? We don't know what this technology is. We need more data, all this sort of stuff. So don't be surprised if that does come. But really the only way to know for now is to see if you're eligible and then submit what's known as pre-authorization, where the insurance will tell you if they will pay for it or not. And if they don't, I think what's reassuring that I tell patients is while histotripsy is phenomenal and a really exciting new technology, usually almost always you have another option. So if histotripsy is not an option for you, there will be another option for you. And actually, the majority of patients that I'm currently seeing who reach out to me specifically for histotripsy, unfortunately, I'm not able to offer them histotripsy for many of the reasons we've talked about, but I almost always give them another option of something liver-directed or something systemic that would be available to them. So there's a ton of great clinical trials and things like that. So just don't be discouraged, I guess, is be the main thing if you're not eligible for histotripsy. It doesn't mean that you don't have options the vast majority of the time.
Thank you for that. And I know today we've really focused just on ablation and especially histotripsy, but if we could just end with this question, how do you decide then between the various types of liver-directed therapies? I'm glad you mentioned that there are options. It's not just this one narrow focus of just histotripsy or ablation in general, but how do you decide what to offer?
So deciding, honestly, we spend conferences answering that question. But with that said, some of that is going to be also nuanced in operator preference. So you may go one place and they say, we do histotripsy for that. And then you go another place and they say, oh no, we do focal Y90 for that, or focal radioembolization, or we do cryoablation or whatever. But the very broad way to think about this is if you have a few tumors, so like we said, 3 tumors less than 3 centimeters, then that's prime for an ablation modality, meaning I like to use the analogy of like a sniper. You want to go in and snipe that tumor because you only have 1 or 2 of those tumors. Now, if you have many tumors, you can't go in and snipe 1 or 2 of them. You need something that blankets all of them. And so the intraarterial therapy is where we go into the artery and then release all of our medications, whether that's chemo, radiation, or the bland beads. That's more of a strategy for patients who have multiple tumors. So that's sort of in general, that probably applies to 90-95% of cases. But then how you pick which ablation you want to do, which arterial procedure you want to do, that comes down to your preference, your multidisciplinary approach. All that's very nuanced, but that's in general how we think about these.
Yeah, that's helpful, the sniper analogy. Thank you so much for all you do on behalf of NET patients with your research, your direct patient care, and all the education and energy you bring to this field. We really appreciate you, and we look forward to talking again.
Thank you so much, Lisa. I appreciate it.
Thanks for listening to the LACNETS podcast. Go to our website, lacnets.org/podcast for episode transcripts and resources. We want to thank our podcast supporters, Novartis, Ipsen, ITM, Crinetics, Curium, Exelixis, and Boehringer Ingelheim. For more information about neuroendocrine cancer, go to www.lacnets.org. LACNETS depends on donations to bring you programs such as this podcast. Please consider making a donation at lacnets.org/donate.